So we give them the already active form of prednisone into prednisolone. And so we start them on the fluids, we start them on the steroids, again, and if we need to correct electrolytes and do additives to their fluid bags and things like that, we just make sure it's done slowly over the course of several hours, not like a bolus, like a fluid bolus we would give on a shocky patient when they first arrive. And typically when we start treatment, they respond pretty quickly if it is truly Addisonian. You start correcting these things and they can perk up within a couple days and they'll be back to normal and go home. That's if that's the only thing they've got going on. So then we send them home, and now we've got the owners that need to now understand what just happened and have their compliance, because that is the key to this. If the owners decide not to continue a steroid dose, if they're not consistent with their Percortin injections like they need to, it'll cause them to go into a crisis situation, such as when Kingston Edsall's owner forgot for 6 months to give Percortin, and he came in as a crisis situation. So we do routine blood work in the beginning to check the electrolytes imbalances, and so Zycortal/Percortin is our injectable mineralocorticoid replacement. Since we can't produce aldosterone, this is kind of like our synthetic aldosterone, and so that is gonna try to continue with absorption of sodium normally, decrease potassium. So we need to do blood work frequently to make sure we're hitting that sweet spot. So that's why it's kind of frustrating in the beginning for newly Addisonian patients, is because we're constantly kind of fluctuating with that dose to get that sweet spot where we can comfortably keep them at home and they're not going to just spontaneously go into a crisis situation. We also don't want to give it so we have too high of sodium and too low of potassium, because potassium is still important for just general muscle control and our daily life use. So it's kind of this balance of how low can we comfortably get potassium without being too low, how high can we comfortably get sodium without being too high, and then maintaining that. And so I wrote about it in my paper. It says that Zycortal/Percortin is typically every 30 days, but depending on how the patient's doing, we can stretch it out to like 60 days. Maybe 3 months at max, but that's very, very rare. It's typically in that 30 to 60 day mark that we're gonna have a patient where they have to come in and either get the injection done at the clinic, or if the owners feel comfortable doing that injection at home themselves. And then we're going to want to start them on the oral steroids, so the prednisone or the prednisolone, and the goal of that is to try and get the lowest effective dose possible without triggering a crisis situation. And so I'll just kind of go over, there we go. Steroids have a lot of side effects. I'm sure we all know a couple of these. So the biggest things that we're going to see is muscle wasting and a pot-bellied appearance, and that is because steroids break down proteins over time, and proteins are very essential for your muscle fibers and keeping things where they need to be. They're kind of our building blocks of the body. So as over time steroids break down our proteins, our muscles become weakened, and so abdominal muscles will become weakened, and that's when we'll get that like pot belly, like, you know, appearance to them because of that. Steroids affect the body when it comes to the immune system and poor wound healing, because it suppresses the immune system. So that's definitely something that we need to keep in mind, as well as that these patients, if they get sick with another type of infection, they're not going to be able to clear it as effectively, and they can go from 0 to 100 real quick with, you know, something minor, such as like any dog that gets kennel cough, you clear it with some cough tabs, and usually that's good, but sometimes these guys can quickly progress to like pneumonia because they can't fight infection. They're going to be ravenously eating. Steroids increase that hyperglycemia, so they're going to feel like they have to eat to keep up with that glucose amount. So they're going to be starving 25/8. We're going to see PUPD with them as well, and I won't go too much into this part either, but steroids affect the hormone ADH, which is what controls our diuresis in urine. So it pretty much makes it so we're retaining water in our urine more, So we're peeing it out more. And then again, the higher brain centers say, hey, we're peeing a lot. We need to drink more water to like retain some of that water losses. And then thinning hair coat is, it affects the collagen of skin. So it makes their hair coats look really, really bad. And so I'll briefly touch on this. There is atypical Addison's disease. This is like a whole nother can of worms to open. But pretty much with atypical Addison's disease, it's even harder to diagnose. And again, can send doctors through a whirlwind of UA testing and blood work and doing an ultrasound and maybe x-rays and doing all these diagnostic testing before they're like, atypical Addison's. And I don't know, I'm sure people have heard me joke when we're at rounds and when the doctors are struggling with the case, I'm like, it's atypical Addison's. This is causing their cortisol levels to be decreased, but their mineralocorticoids are normal. So we're gonna see some hypotension, we're gonna see some hypoglycemia, but we're not gonna see the sodium and potassium levels being messed with that much. So we won't see that on blood work. It'll look normal. And we won't see a stress leukogram either because we've got cortisol going. So they could present with completely normal blood work. And so this can be very hard to diagnose. The way to truly diagnose atypical Addison's is, again, doing the ACTH stim test, because we're going to give them synthetic ACTH and see how their body produces cortisol, but they can't produce cortisol. So that is our definitive way to diagnose atypical. Most of the time, these patients will progress to become typical Addison's disease, where they will now have their mineralocorticoid deficient, typically within a few months after atypical. It's not super uncommon for them to switch from atypical to regular Addisonian disease, and then they need the percortin injections as well. And atypical Addison's said it was mostly due to the pituitary gland having a tumor and not sufficiently producing ACTH for cortisol and things. And it says sometimes this is so hard to pick up, you have to do an MRI to do an MRI of the brain and look at the brain and see that tumor. So sometimes we need to do extensive imaging to see this. And again, sometimes doctors won't do the ACTH stim immediately because blood work looks normal, but the animal looks terrible on presentation. So I just want to thank Dr. Lewandowski. She was such a homie G with me for this project. She was helping me read my paper, and she was just such a great asset and meeting up with me. Like I said, I've wrote a whole paper on Addison's if you are very interested and want to read it. These are all the references I used for my paper as well as what I've learned. But yeah, that is Addison's disease in a nutshell. If you have any questions, definitely come talk to me.